Hello and welcome to the VideoGIE Meet the Masters series. I feel extremely privileged today to be able to interview my mentor and my friend, Dr. Christopher Gostout. Chris, as many of you know, has acquired innumerable accolades. Most notably, he is the past president of the ASGE. He is a recipient of the Schindler Lifetime Award and a mentor to many accomplished national and international physicians. I am Elizabeth Rajan and a gastroenterologist and therapeutic endoscopist at Mayo Clinic, Rochester here at Minnesota. So my hope is for this interview we will perhaps learn a few little known factoids about Chris, but more importantly, to hear his story of being a leader, an innovator, a visionary, and an out-of-the-box thinker. So, well, perhaps we can start firstly by you telling the audience where you were born and what your childhood was like.
I was born in New York City, in Brooklyn, and shortly thereafter we moved to Staten Island, and that's basically where I grew up, on Staten Island, New York City. That was the selection because my parents wanted to have a little more country life as opposed to urban life, and Staten Island at that time was fairly undeveloped, and so I grew up as a kid playing in ponds, catching turtles and frogs, and dissecting frogs. I truly believe that being a physician for me was a vocation. As far back as I can recall, I've always wanted to be a physician. And my mother actually saved an essay I wrote when I was in the second grade. And it was entitled something like What I Want to Be. And in that story that I had written, my goal as a second grader was to spend 6 months of the year as a neurosurgeon and the other 6 months of the year as a forest ranger. So it went back a while. So for me, it was a vocation. And throughout my education, that was my primary drive, was to continue to be a physician. I don't think I ever swayed from that. When I was in high school, I was really keen on going to the U.S. Naval Academy and becoming a physician, a naval physician, and getting into the space program and become an astronaut physician. However, these things prevented that from happening. And so I followed a different path, a path that ultimately led me here to Rochester.
So that is somewhat unusual that from a very young age you chose medicine and stuck with it. And were there role models, were there physicians in your life, or did you just
not really. It was just something I thought that's what I wanted to do, and it seemed to me to be the best choice.
Then Chris, medical school, so tell us a bit about your medical school and residency. So you make that decision, you're going to be a physician, and you get in.
Yeah, so I went to medical school in Brooklyn, New York, and I went to SUNY Downstate. I had a professor at Villanova that spoke extremely highly of Downstate and kept drilling me on, go to Downstate, it's a great place. And I applied to a variety of medical schools, and ultimately I thought that was the best fit for me, and it was a fantastic experience. I was more than pleased with the opportunities I had, the education I got, and where it's led me. And that's when I became interested in gastroenterology. In fact, during the first week of medical school at Downstate, they paired you up with a clinician, and you had to go meet this person in their office or hospital setting. And I was paired up with a gastroenterologist who at that time was the chairman of the department of GI. It wasn't very big. And he was a bit of a character. He was a cigar-smoking guy who actually smoked cigars while he was doing colonoscopies. And that caught my eye, that is, doing flexible endoscopy, and in the range of clinical problems that I was introduced to as a duckling imprintable first week first year medical student, and the thought of going into GI lingered with me throughout medical school. I was diverted a few times, and but I ultimately swung back to wanting to stay in GI.
The mentorship then, when you were in GI, or how did you get to become a therapeutic endoscopist? What drew you?
Yeah, I came to Mayo as a medical student and did a rotation in GI and met several of our very senior consultants, some of whom are not with us at this time. And I met a man called Raleigh Hughes, who was the endoscopist for the Mayo Clinic. In fact, he spread over several disciplines, including urology. And he was somebody that caught my attention, and we spent a fair amount of time talking, and he introduced me to endoscopic procedures, and he also introduced me to the idea of thinking out of the box and how you can do more with what we're doing at the present time. And so Raleigh was predominantly my mentor, especially through my GI fellowship, and kept me interested and kept pushing me towards endoscopy, and more to think about the therapeutics that could be developed in endoscopy, and how it was really needed that. And that was my mentor, Raleigh Hughes.
After you've got into this therapeutic endoscopy, you go into innovation in a very big way, and you have innovated endoscopy practice and also innovations of technology. So can you share with us some of your joys and your pride in initially the practice, and then we can move on to the technology?
As I evolved as an endoscopist here at Mayo, one of the key people who actually allowed me to flourish is one of our former division chairs, Nick LaRusso. When he took over the division, he had a vision that our division should expand and flourish in all the subsets, subspecialty areas of gastroenterology, including endoscopy. And he encouraged me to actually develop the concept of the developmental endoscopy unit, and gave me the flexibility of time to create the DEU. At that time, the biggest feather in our cap was the GI bleeding team. And that was a response in therapeutic endoscopy to a growing demand by our surgical colleagues to do something other than look down a patient or up a patient in the setting of acute GI bleeding, but offer some therapy, which we were not doing at that time. And so the GI bleeding team was intended to offer the therapy, examine the therapies we offered, and make some decisions on how we can improve endoscopic care, at least in that setting of emergency endoscopy for GI bleeding and other related issues, food impaction, pseudo-obstruction. And the bleeding team flourished. A lot of opportunities to report on our experience and the concept of the GI bleeding team. And then the developmental endoscopy unit developed. That was in 1998. And that's what really got me thinking about, well, what do we really need, or what's missing in endoscopic therapy? We're doing GI bleeding now. It's kind of a ho-hum. ERCP is moving along. There is endoscopic ultrasound, but there had to be something else that was important. And at the same time, in 1998, I banded together with the Apollo group. And this was a concept to develop endoscopic procedures out of the box. I remember sitting on a morning in, I think, Maui, on a Sunday morning with Rob Hawes, and having a discussion about where can endoscopy go. And the idea came up to put together a group of people, like-minded, with good chemistry, and that's where the concept of the Apollo group started. And it was Jay Pazricha named the group the Apollo group because of the the association with the space program and the achievements and out-of-the-box accomplishments of the Apollo program, which I kind of liked, being a dreamer about being an astronaut. At any rate, that launched innovation. And my thought at that time was that we needed to do a better job at tissue manipulation. And so the theme of the developmental endoscopy unit was, the main theme was how to improve excision of tissue and repair of excision defects. And so you spent a long time in the animal lab trying to figure out how to excise tissues, but using two hands. Remember, that was your task. Because I thought this holding a scope was a hindrance for any kind of evolved complex therapy. We had to let go of the scope, and we built a special scope stand so that you could try working through two channels and manipulate and excise tissues. Well, it was pretty difficult task. And but we persisted with that, and we came up with some really cool ideas like WEMR, widespread endoscopic mucosal resection, submucosal endoscopy. That was probably the most exciting thing that that I had conceptualized. Is you know, I had seen, and all of us had seen, the mucosa separate from the submucosa in a variety of settings, mostly accidental, and but the fact of the matter is, it did isolate the mucosa. If you blew a little too much argon gas into the bowel wall, poof, up came the mucosa. And sometimes when you were doing a dilation, the mucosa would shred with a split. And it clearly was separable, or it did delaminate from the GI wall. And that's what got me excited. I thought, you know what? We're always working in the wrong direction. We're working towards danger, right? Towards the outside of the bowel. And if we could just turn around and work towards the lumen, things would be a lot safer, and we could maybe do more than we're doing right now in a relatively unsafe direction. And by burrowing in and creating a new working space, the submucosa. Poem, right?
Right.
People are doing STIR, you know, removing subepithelial lesions by tunneling. People are, my ambition at that time was to enable mucosal resection as opposed to working in a tunnel per se. And but people are now tunneling to enable and facilitate ESD. I think it's a logical thing. And so that was probably the most exciting thing I think we did here in the developmental endoscopy unit. We played around with submucosal fluid cushions to try to identify a cheap, effective, long-lasting submucosal fluid cushion, and that was a big success. And then also to enable dissection, the use of Mesna as a submucosal softening agent, and it was kind of cool stuff. The latest and the greatest has been the magnets, right?
Yes, yes.
We live in a world of magnets. Magnets are everywhere. Your automobile has like hundreds of magnets in it to make things work, and why can't we use magnets to enable us in the GI tract? And that's been the most recent exciting project.
And then you've been involved in so many projects and exciting innovations. And I think, did you want to touch on all your obesity work as well with the suturing device and the ESG? I mean, all of that started before it was popular as it is now and as successful as it is now, Yeah,
so it was around 2004. 2004 was an important year. That was the big year of developing the submucosal program. And it was also the year we started to try to figure out an endoscopic weight loss procedure. And we looked at everything and anything under the sun and to see if we could figure out a way to have patients lose weight. And our answer was to reduce the volume of the stomach. Another project that you also worked on for a very long time. And that was the time when we had EndoCinch, and with the Apollo group, the Eagle Claw device, suturing device, surfaced, and we struggled with EndoCinch for a long time, and it failed. And the problem we had was we couldn't get deep, and especially full thickness sutures, to compartmentalize the stomach. But the ultimate goal And the ultimate identification, once we had a really solid suturing device in our hands, thanks to the Apollo group and the overstitch device, we could finally reduce the gastric volume and create the endoscopic sleeve gastroplasty. And so that technique was tried in pigs, it was tried in dogs, and it was even tried in the baboon stomach. And it was pretty clear, finally, and now we're getting to about 2012, that this is a doable procedure, that we should be able to endoluminally reduce the stomach volume at least 80% and in effect true useful weight loss for patients. And that's how the endoscopic sleeve gastroplasty grew, and that was a pretty hot development, I think, and a great career milestone to have surface with it.
Innovation in your blood, or is that something that we can all learn, be trained in, and is it something that we should really strongly promote in our young trainees as well?
Right, that is a fantastic question. And I think there are some people for whom innovation is in their blood. You know, they're tinkerers, have always been tinkerers, and those people do manage to succeed in innovating. And I've been somewhat of a tinkerer for sure, but throughout my career, and especially when our DEU fellowship started, I thought this is a chance for giving an individual an opportunity to innovate. So people came to participate in the different studies we had, to witness a variety of clinical endoscopic procedures during the research fellowship. But it was a clear point that I had to share with them, that if they were going to come and work in the developmental endoscopy unit, they're going to have an opportunity to innovate and try to create something beyond which we're assigning them to do. And that actually, most of their time could be spent just doing that. So I think there is I think people do have the opportunity to innovate. If you're a clinician, a hardworking clinician, every day you're seeing things that could be done better, or tools that could be improved. And these are things that come and pass. You know, the light goes on, you think about it, and then you forget about it because you get involved with the tasks of the day. And but if you can just pause enough to think about that, and then take it with you and think some more about it, and then have an opportunity to apply it and try to do what I call the Home Depot experience, where you walk into Home Depot with the idea and you look through all the tools and things that are there for materials to get an idea of a technique or a method. You know, what's out there already that could maybe be applied or enable something to happen. And so I think every individual can innovate to varying degrees, but it's having the discipline to recognize an idea, hold the idea, and then try to move on it. And the best things that are created are the simplest things. And so it doesn't have to be a very complex idea. And I think most people can do that.
Okay.
Not everybody, but most people.
What would you advise someone who is trying to create a device or technology? Would you advise them with the notion that it's a struggle, and oftentimes failure follows you, but if you persist, success it may occur. So what advice would you give those who are starting or thinking now? They hear you and they've got an idea and they want to go out there and do it?
Well, first of all, I'm a true believer in the physics of life, and everything follows a sine curve. So there are peaks and valleys. So there are times when success seems imminent and things are all working and seem to be the planets and the forces are aligned, and there are times where it's despair. You know, nothing's happening. I think there's a couple of messages. Persist. You need to find time to clear your head. And so work finds you. There's no doubt about it. And so you have to identify a way to escape from the demands of clinical work. And whether it's identifying how you can acquire protected time, how you can remanage your lifestyle to take some extra time to quietly think and apply your ideas to whatever is striking your fancy at that moment as an opportunity to innovate. So you need time. You need time to think. You need to connect. So networking is extremely important. A lot of times somebody else has thought about what you've thought about, and that person may not be in the same discipline. And so you have to keep your eyes and ears open to your colleagues in other disciplines so you can share these ideas and try to get some input from them. Sometimes they can show you something that they have that might enable your project. You also have to look elsewhere. So you have to keep your eyes open to new advances in technology. And I'm not referring to electronics, but materials, new materials that are being developed, chemicals that are being developed. Some of those have direct applications for use in endoscopy. So you have to kind of keep your eyes and ears open to everything in the world about you, reading about it and talking to people. But networking is really, really important.
So Chris, now I'm going to ask you about if you could go back in time, is there anything you would do differently?
The only thing I would like to do differently is I would like to go back in time and redo college. Knowing what I've learned and experience I've had, boy, I'd tell you, I'd love to go back to college. It'd be a great time insofar as, and I'm just talking now just about learning. I think the learning experience would be vastly better. But otherwise, no, I don't think I would repeat anything. You know, life goes on, and we follow a path, and we try to do the best we can following that path. And I don't have any regrets about anything. And yeah.
Then, what are your proudest achievements or things that you hold very close to your heart?
Insofar as my experience with the ASGE, okay, two things that I'm really proud about is the IT&T Center, and I think the concept of having a go-to center for the ASGE was valuable for that professional society, and the hands-on lab, especially the hands-on courses that I think I was instrumental in allowing to grow and flourish. I'm extremely proud about that. The second thing is the establishment of the first-year Fellows Endoscopy Program. When I was president of the ASGE, I created a list of things that I wanted to accomplish, and that was at the top of my list was to establish a uniform first-year Fellows Endoscopic Program. So any fellow in any program, we can even the playing field in exposure to endoscopy, get them thinking about endoscopy, and even dreaming about endoscopy. And that's the purpose of that program. And that program has prevailed. I've been more than excited to see that it continues year after year. In my career here at Mayo, I'm proud for the developmental endoscopy unit. It's been I think a fountain of ideas and success that I think has been a real accomplishment. I think the GI bleeding team was probably one of the largest accomplishments in my career, putting that into place.
How was that transition? And I ask this question as, you know, there are people watching this that might be coming close to retirement. What advice would you give them, you know, with regards to transitioning and making your retirement a healthy, happy time?
All right. Well, first of all, I live under the thought that life is too short, and you need to make the most of life. And so I, I have constantly watched what I've been doing, what occupies my time, and and I and you hit a point where if you evaluate yourself well enough, you can identify satisfaction. Have you achieved satisfaction in your adult life? And in this case, we're talking about your professional career. Have you reached a point of satisfaction where you're content with who you are and what you've given, what you can offer, and that's the turning point. And so I hit a point where I thought, you know what? I know I'm comfortable with who I am in the world of gastroenterology and gastrointestinal endoscopy. And I think I'm at a point where I don't need to take up space for those who are younger than me and who have the same ambitions as I've had. And I think there's a point in time where it's important to step down and move away and let others have that opportunity that you've had. And so I hit a point where I thought became very self-conscious that, I really don't need to give this talk or that talk, or I don't need to participate in this or that because somebody else should have that opportunity, not me. I've had the experience; it's been phenomenal, and I've enjoyed it, and I certainly enjoy doing it. But somebody else needs to do that, and that was the turning point for me to realize that okay, it's time to step out of the limelight and do some other stuff. Again, life is too short. You gotta have fun. You gotta have fun. You gotta enjoy life, and it's not all work.
Do what you feel good at, and
yeah.
Chris, the other thing is, what are the key ingredients you would say for success? The key ingredients, if you were to pick the top 3 things that you would say someone needs to have to hit your level of success.
Right. So be good. Take care of yourself, meaning sleep well, eat well, and exercise. I'm a devotee of that. Interact to the best you can with your colleagues and those even outside your profession, as I mentioned, networking. Keep your mind active by thinking ahead. Never be complacent. You should never truly be complacent. I realize I've just spent 5 minutes talking about retiring and hitting a point in complacency, but that's a turning point. So you have to keep thinking of the next step or how to do things better and how to improve what you have. Or even your interactions with other people. How can you do that better than you've been doing it? Complacency is not useful. So those are the key elements, I think.
So then finally, Chris, you have been the master of disguise, from Moses to Jack Sparrow. So I want you to now don on your fortune teller outfit and with a crystal ball in front of you, where do you think GI endoscopy is headed, or what it might look like decades from now? Do you think we'll still have our traditional endoscopes, or would there be very disruptive technology ahead?
Yeah, so that's something that I think about a fair amount, and a couple of things. I think endoscopic systems are going to become more intelligent, and so I think the endoscope of the future is going to be an intelligent instrument, to the point where it may not be necessary for a physician to perform all procedures. I know, this goes on, there are non-physician endoscopists, but I think the endoscope can get smart enough that it'll arrive at a point where you don't have to be a physician necessarily to perform very basic endoscopy. It can also become, and I'm hoping it'll become smart enough that will enable those of us that are doing interventional endoscopy to do a better job in it. Tell us endpoints, give us fair warning when to be more careful when we're doing something. So I think smart systems, artificial intelligence, definitely has a role in endoscopy and will have a role in endoscopy. What about the optics? A scope can certainly get better than we can see and perceive. And again, that's where AI can come in. But I think there is room for improved resolution and providing image to the human eye to improve the experience. So I think the endoscopes get smarter, will give us better pictures. So the big question is, when are we going to let go of the scope? Or when are we going to start to use two hands in an endoscope? I don't believe that robotics are going to become a part of our future, meaning in the next 10 to 15 years, because of expense and complexity of the technology. But I do think that smart people and smart companies are going to enable us to let go of the scope and use two hands to manipulate tissues. And I think that's the big thing I'm looking forward to the future, is two-handed interventional endoscopy. Insofar as types of procedures, it's pretty clear that as we become more comfortable working with the various layers of the GI tract and even outside the GI tract to manage issues like abscesses and collections, post-pancreatitis, that we're getting more comfortable with the anatomy inside and outside of the gut wall. And so I think, I'm positive in the future we'll be way more aggressive in excision of tissues. And I think full thickness resection, it's something that gets talked about. It's, white papers have emerged on the subject. It's not there yet. There's a lot to go, but there'll be a point in time where this will become a routine activity for the interventional endoscopist.
Chris, this has been great, and I want to thank you very much for doing this interview. And
my pleasure.